I'm going to be talking today about Syrinxes that are unrelated Chiari Malformations and have no disclosures. So basically, in talking about a primary syrinx, this is considered to be an orphan disease, given its rarity of 1.4 cases for approximately every 100,000 members of the population. I'm going to go in and define the different types of syrinxes, this being the initial statement, but I'll get into a little more detail about this. But essentially, talking about the extent of the syrinx superiorly. So basically from the cord, heading up into the medulla, which is Syringomyelia, extending further into the pons, which is Syringomyelia, extending to the midbrain, which is Syringomyelia, and then Syringocephalus, which is very rarely seen, which is extension into the cerebrum. Syrinxes tend to be tissue-based, so that's going to be really the primary differentiating factor. A lot of times on a film, you'll see a central canal that's enlarged. People will be going back and forth as to whether this truly represents a syrinx or not. But there really is, by definition, a difference. Hydromyelia is essentially a fluid accumulation or dilation within the central canal. And so this is what I was talking about, is that you can see sometimes significant dilation of the central canal. The important thing conceptually is that this is lined by ependema. So this is truly within the ependymal lining of the central canal. The difference with the true syrinx is that it's a cavitary lesion. It involves the parenchyma of the cord. It can have some involvement of the central canal, so there can be some lining with ependema, but also a great majority of it is extending into the parenchyma of the cord, and that represents a primary difference. Just kind of in a basic way, if there isn't a complete ependymal lining around the cavity, then that would be what I would consider to be a syrinx. This is what I was mentioning earlier in delineating what the extent is cranially or superiorly of a syrinx or a fluid collection within the parenchyma of the cord. Heading up into the medulla is where you get Syringomyelia. Heading up into the pons, Syringomyelia. Heading up into the midbrain, and then once again, if you head up into the cerebrum. The importance of this is the presentation can differ. So based upon the ascent of the syrinx cavity, you can have a different presentation in different patients, and these are progressively more severe as it ascends. Becomes more problematic, not only in diagnosis, but for the patient in general. So in talking about primary acquired syrinxes, there's different mechanisms by which we will see these. Traumatic, atraumatic, and tumor-related. For those that are traumatic, there's a direct trauma. It can be a contusion or an indirect injury to the cord, a penetrating injury to the cord. Surgery, anything we do surgically involving the cord, whether it be for metastatic tumor, primary tumor, or any involvement with the cord whatsoever, can result in scarring, which is traumatic in nature. A bleed into the tissue of the cord or the subarachnoid space, or even subdural blood can be considered to be traumatic. And lastly, a stroke, dead tissue, basically an infarction of the tissue of the cord. Atraumatic, ischemia with associated swelling. Tumor with associated swelling or mass effect. Stenosis spondylosis, which essentially is a bony abnormality of the spine that diminishes the CSF space around the cord. And as I'll get into, this is the most significant problem in syrinx formation. Lastly is tumor, intrinsic tumors, extrinsic tumors, cysts associated with tumors, and bleeds associated with tumors. Somewhat different in that these bleeds are defined as occurring within the tumor mass itself and not disparate or of a separate etiology. Anything we do, surgically speaking, and any insult to the cord, whether it be immune, infectious, can result in an arachnoiditis. And arachnoiditis also diminishes the capacity of the cerebrospinal fluid space around the cord. And this is one of the reasons one can develop a syrinx that is unrelated specifically to mass effect, as I'll discuss in a bit. And any of the various etiologies that are traumatic or otherwise can have secondary inflammation and scar formation, so that the primary insult in and of itself may not be enough to create a syrinx, but with associated inflammation can kind of push us over the edge to where we start to have a cavity formation. So the way that I like to think about this is the presentation. Post-traumatic injuries manifest with progressive neurologic deficits, usually above or at the level that can occur months to years after the initial trauma. The incidence of associated paraplegia with the syrinx formation is 1 to 4%. We're starting to see more and more syrinxes associated with trauma. It's difficult to say whether this represents a true increase in the population, but it's much more likely that people are much more aware and observant of a progressive symptomatology, and we have better imaging, both of which will likely allow us to predict these much more quickly. We're also more diligent in obtaining images after spinal cord injury or any insult to the spine in general, and I believe that this is moving us in the right direction. Spine disease, stenosis of the spinal canal, spondylosis or disc disease, which are primary problems of the bony elements of the spine, all really create an issue by diminishing the CSF space around the spinal cord. Post-inflammatory etiologies, these can be rather immediate or delayed, but both to infectious, whether it be viral or bacterial or chemical inflammation. One of the problems that we've seen with graft placement for Chiari decompressions where grafts are placed is that we can get a chemical meningitis in relationship to the type of graft material that's used, and this can be pretty broad in who it impacts and who it negatively impacts. We've tried a myriad of different graft materials and have found problems almost universally. But this is problematic, and this can also be related to eventual syrinx formation. Tumors, whether intrinsic or extrinsic, also relate to a number of issues that can be associated with syrinx. The tumor itself and the mass effect, the involvement for intrinsic tumors in the CSF, associated scarring with or without surgery, bleeding, tumor cyst cavity formation, all of these can be associated with syrinx formation. When we do see a tumor, specifically an intramedullary tumor, and we do see tumor fluid associated with that, it's usually the belief that the fluid is resulting from the tumor itself and is not secondary to true syrinx formation. The primary component that we're talking about is going to be the movement of fluid into the cord. So this would be an axial section or cut through the cord, and all of the vasculature is moving through subarachnoid line spaces within the cord. And it is the aberrant movement of fluid into the cord that is really believed to be one of the most likely causes of syrinx formation. So this is a normal cut trying to explain the anatomy, essentially, of these spaces. And these are called Verco-Ruban spaces, both in the spinal cord and the brain. You see, this is the subarachnoid space, the parenchyma of the spine. This is a blood vessel. This is the outlying dura. And so there's a normal dynamic of flow throughout the Verco-Ruban space that is not under pressure. And it allows for interstitial fluid movement in this space and the removal of waste products and delivery of certain nutrients and such, but also for pressure regulation. And I guess the premise that I think is most likely, and really described by one of the board members of this foundation, is that with systole, you get expansion of the brain, which creates a CSF pressure wave. And essentially, the CSF pressure wave is heading down both anterior, posterior, and laterally to the spinal cord, or the tissue of the cord itself. If there's an obstruction in this space, then the normal damping that you get of the wave progression through the fluid-filled space is altered, creating a redirection of force. And that redirection of force is through these Verco-Ruban spaces into the subarachnoid space. And this would be the normal flow, in this case, anterior to the cord. And essentially, you're creating an environment where fluid is being forced into these spaces. This fluid could then coalesce and become a syrinx. The fluid is directly heading into the parenchyma of the cord, obviously, but can. So the problem is that the dissipation of the wave itself, or the normal dampening, doesn't occur. And what that does is creates a redistribution of force, essentially forcing fluid into these spaces. And this can be created by an obstruction, or it can additionally be created by partial occlusion or total occlusion of the subarachnoid space. So it's important to understand the concept of communication, and to have a communicating or a class of communicating fluid-filled space means that the central canal will communicate with the fourth ventricle, as you're seeing here. Non-communicating means you have a dilation of the central canal below a syrinx-free segment of the spinal canal. So here you have the fourth ventricle. Here you have a central canal abnormality or increase in size, but basically an unimpacted zone in between. If something's considered to be extracanalicular, it means that there's a cavitation that arises in the parenchyma of the cord and has no communication with the central canal. And this is specific to syrinx in that a syrinx obviously doesn't need to have an associated ependymal lining and can be purely parenchymal in nature. So just as a general summary of the mechanism, this being the cord, this being the CSF space, you have a mass within the cord. If you have associated expansion of that mass, you create an obstruction. And so the damping phenomena of the fluid wave is modified. And that modification creates one kind of a redistribution of force, but also turbulence. And the combination of those factors will inhibit further progression in the CSF space inferiorly, but create a problem where this force is now distributed into the parenchyma of the cord. A similar phenomenon is with arachnoiditis, infection, scarring, or something else that is creating an occlusion or an increased resistance in the CSF space, which will then result in essentially the same type of a phenomenon. With regard specifically to trauma, about 1 to 7% of people with a spinal cord injury have been reported to develop clinically symptomatic syrinxes. As I had said before, is this actually increasing? I think paying more attention, obtaining more images, better imaging systems, better understanding on the part of patients, and longer follow-up are all increasing to these or leading to these increased numbers. I don't know that there's actually an increase in the actual incidence of such. Trauma can result for many reasons in an obstruction of the normal CSF flow. This is a compression fracture. You can also have spinal cord scar tissue form as a result of the trauma, hemorrhage, arachnoid adhesions, penetrating injuries, kyphotic deformities. Whether it's detected or undetected trauma, you can have associated scarring of the arachnoid, in addition to just over time and age, progressive and acute spinal canal stenosis. And what this does is basically diminishes the CSF space around the cord. This basically gives you a sense of multiple potential injuries. One is mass effect with occlusion of the canal, but additionally, you can see that there's a contusion of the cord and associated swelling. So you have swelling, mass effect, ischemia, likely blood, and all of these factors will then lead to potential for syrinx formation. Timing, that's why long-term follow-up is essential, is that the timing can be significant following the injury. These can really form as early as you start to see dissipation of a hematoma cavity associated with the trauma. The post-injury to diagnosis of a traumatic syrinx can range from 9 to 15 years, with a range actually of 1 month to 45 years post-injury. Given that there's a larger thoracic space, thoracic location tends to exceed that of cervical location following trauma. The incidence is increasing in older patients. It is also increasing the other complete injury with no functional recovery. Tumors, as another etiology, the imagery that we get with regard to tumors now can really give us a good deal of information and lead to many assumptions, but also create an environment where we get serial studies given the likelihood of somebody forming a syrinx. And this can be the size, location, length, extent of surrounding edema, spine, tumor interface, associated cystic changes, and such. It also gives us a sense of the type of tumor and specific variables associated with that are associated with syrinx formation. Astrocytomas, which can be locally invasive, obviously don't have well-defined borders, but can have large satellite cysts associated, especially with lower grade tumors, and especially in the pediatric population. We tend to see bleeds into the tumor more commonly in ependymoma. Cholangioblastoma have neural nodules, are associated with a syrinx and can have significant surrounding edema. There's also an assumption that the nodules are well defined with regard to a plane and can be easily surrounded from the surrounding spinal cord tissue, and this isn't always true, and you can find a great deal of scarring, especially with recurrent bleeds. The outcomes for patients with intramedullary spinal cord tumors tend to be guarded. Those patients presenting with deficits at the time of presentation have worse outcomes. Metastatic disease, whether there's a syrinx present or not, tends to be associated with significant mortality, with most patients rarely living beyond 12 months, much more significant in the adult and the pediatric population. Pain control, almost universally a challenge. The problems with the associated syrinxes, pain, neurologic deficits, and such really require a multidisciplinary approach to the care of these patients. The pain requirements in and of themselves usually require a critical care specialist and specifically a pharmacist to try to assist the clinical team in coming up with pain relief that's adequate, but also long-lasting long-lasting and potentially lifetime in nature. And these are just interesting images of spine disease, not traumatic in nature, but occurring over the time, sometimes congenital, but all of which are associated with diminished capacity to dissipate this normal fluid wave in the CSF space around the core. Spondylosis is another factor that needs to be followed over time. Syrinx is rarely associated with cervical spondylosis, but it's believed that there's an adhesive arachnoiditis at the spondylosis site, and usually the size of the syrinx will be directly related to the severity of the spondylosis. Usually the syrinxes will occur distal or below the spondylosis site, but can be at that site or more proximal. Once again, it's the same believed mechanism where you have a decreased dampening of the fluid wave, really kind of a speed bump, if you will, that will lead to a redirection of force and an increase in interstitial fluid, which then results in syrinx formation. This has really been looked into in detail with one study placing CSF tracers and seeing essentially movement of the CSF tracer from the arachnoid space into the cord perivascular space and eventual cystic cavity, really kind of supporting the fact that it is this aberrant movement through the CSF spaces into the cavity that are responsible for syrinx formation and progression. With regard to management, the primary approach is to approach the disease process itself. In patients that are symptomatic, surgical correction of a spondylosis is really the primary goal without concentrating our efforts on the syrinx itself. What we need to do is deal with the primary problem and then follow serial films and serial exams to see if we can create a dissipation or resolution of the syrinx itself. In an asymptomatic patient, having the syrinx remain the same size is okay. Getting smaller, obviously, is preferable. Having it dissipate completely is also most preferable. Marsupialization, primary drainage, removal, all of these are not considered to be primary approaches to a syrinx when it's associated with spondylosis. And as I said, those patients with asymptomatic syrinxes usually will stabilize neurologically or have spontaneous regression of their syrinxes without surgery if we watch over time. And this is following the primary correction of the spondylosis or the spine deformity itself. Awareness is really the importance of these type of conferences, these type of lectures, and gives us a better chance of not only defining the disease, but treating the disease appropriately and having some success in doing so. Pain really is the most commonly reported symptom. Trying to figure out, does this actually mean something? What is the relationship to the syrinx? Can be difficult, especially when you're dealing with spine disease. The pain is usually located at the level of the syrinx, but if present, is usually diffusely present below. It can be described in different ways, but aching, burning, stabbing, tender to light touch or pressure, all of which have been described and are things that we use to look for in our exams. The pain can increase with Valsalva, being constipated, pressing down, exerting yourself, coughing, sneezing, sitting up. Additionally, tissue tenderness in the zone of injury, almost being described as a bruise, can be worrisome and indicative of an associated pain profile. We need to follow these patients closely to determine, is there a sensory level, is it ascending? And that's why the neurologic exam and serial exams are really crucial. Also, loss of function is essential to follow and requires a close relationship between the patient and the surgeon or the caring physician. Are they losing important neurologic capabilities that potentially, in the absence of any kind of treatment or follow-up, are something that can't be regained. Our exams, is there increasing numbness or weakness? Weakness tends to be later as opposed to earlier. Is there a sensory dissociation, namely selective loss of pain and temperature with really preservation of dorsal column function, which is touch and pressure?